Good morning, all. It is 2 minutes past top of the hour, and so I think we will go ahead and get started. I'm Alex Isakov. I'm an emergency medicine and EMS physician here at Emory University, and I want to welcome you to the Emory SCDP, or Serious Communicable Diseases Program, ECHO program. Today's topic is Clade I Mpox, raising awareness and revisiting progress. Next slide, please. All right, some of you may know what ECHO is, and others may not. The acronym stands for Extension for Community Healthcare Outcomes. Think of it as a big grand rounds forum where through telemedicine, mentoring, we actually can present a case and talk about best practices for management of that case, talk about the pathophysiology and considerations about patient management, and then really improve everybody's knowledge about the topic and the competence to manage patients with Mpox, be more familiar with the topic. It was used expertly during the COVID-19 pandemic and hope to continue using it. Thanks to those at University of New Mexico that founded this ECHO program. Next slide, please. So some technical reminders. The first is that if you're experiencing any IT issues at all, please send a message to IT Echo in the Zoom chat. You're probably familiar with the chat function that's at the bottom ribbon of your Zoom screen. And then if you have a question for any of the presenters, then please put it into the Q&A tab, which is separate from the chat tab. Just put it in Q&A, and the presenters at the end of the program will look at those questions and try to answer as many as we can live and try to provide some written responses as well. Next slide, please. So great news for those looking for continuing education credits. This program is awarding continuing medical education credits by the AMA and the ANCC. In order to get those, you do need to complete a survey at the end of the program. Next slide, please. All right. Well, we want everyone to know that the presenters have no financial disclosures to share. And so this is a completely presentation without conflict. Next slide, please. So this is the agenda, typical for SCDP ECHO rounds. We will do introductions of the speakers, and then we will have an HHS Region 4 situational report that I will turn to Yasmin to play. Dr. Gavin Harris actually does a recording if he's not doing it live, and we'll play that recording. We'll also follow that then with some poll questions, and then there will be a case presentation, a didactic presentation on Clade I Mpox, and then we'll move to Q&A, closing remarks, and then we'll finish with the poll questions one more time. Again, if you want the CME, please remember to complete the survey at the end of the program. Next slide, please. All right, well, let me turn to introducing our presenters. So first, our case presenter for today's session is Dr. Jonathan Grein, colleague and friend, and infectious disease physician and director of hospital epidemiology at Cedars-Sinai Medical Center. Dr. Grein is a clinical professor of medicine at UCLA, co-chair of the Infection Prevention and Control Committee, and since 2016 has served as the principal investigator for Cedars-Sinai's Special Pathogens Program, which includes their biocontainment unit. His research interests lie in medical countermeasures, infection prevention practices for both emerging infections and high-consequence infectious diseases, and the provision of care to patients needing high-level isolation. Next slide, please. I'd also like to welcome Dr. Boghuma Titanji. She's physician scientist and assistant professor of medicine here at Emory. Dr. Titanji has had 3 career interests: translational and clinical research in HIV and emerging infections, including Mpox, science education and communication, and global health equity. She's currently focusing on translational applications of inflammation as a driver of cardiovascular disease in people with HIV. Globally, she's passionate about promoting global health equity through research capacity building in Africa and influencing health policy through advocacy. Lastly, Dr. Titanji serves as section editor for Diagnostics and Laboratory Medicine with the journal PLOS Global Public Health and is chief scientific advisor to Critica, a nonprofit aiming to improve health and safety decisions through combating misinformation. Thank you to both of you for joining this ECHO session. And next slide, please. With that, we're going to turn to the Special Pathogens Situation Report recorded by my colleague and friend, Dr. Gavin Harris.
Hi, I'm Gavin Harris with the Region 4 SITREP. First, to Tanzania, where the government has confirmed a new Marburg virus disease outbreak. On the 20th of January, one confirmed case and at least 30 suspect cases in the northwest region of Kagera were reported. This is the same region where Tanzania experienced the country's first Marburg virus disease outbreak in 2023. This region is a populous region in Tanzania and a regional transport hub bordered by Uganda, Rwanda, Burundi, and close to the Democratic Republic of Congo. International teams are deploying to the area as the WHO has classified the regional risk level as high, though global risk as low. More information will be forthcoming. Next, to Nigeria, where Lassa fever virus infections continue. As of the 12th of January, the Nigeria Center for Disease Control and Prevention reported 484 suspect, 143 confirmed, and 22 deaths from the virus since the beginning of the new year. This is consistent with prior seasonal statistics, and as Nigeria is now entering the dry season, we do expect case numbers to rise. In 2024, the country recorded 9,685 total suspect cases, with 1,187 confirmed and 191 deaths. The country has activated their Emergency Operations Center to coordinate response activities. Lastly, to India, where within the first 2 weeks of the new year, the state of Karnataka recorded 2 positive cases of Chiasson forest disease, or KFD. This is also known as monkey fever. Both patients were treated with aggressive supportive care and are now recovering. Finally, there have been no reports of suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdu.emory.edu.
Thanks, Yasmin, and thanks, Dr. Harris. All right, with that, let's move to poll questions. We'll post the first one. First question is, how knowledgeable do you feel about the current epidemiologic state of Mpox Clade I? Pick a choice. And question 2 is, how confident do you feel about the appropriate clinical management of a patient with Mpox Clade I? And pick a choice. We'll give you a little bit to put some answers into the poll. Sorry, Jonathan and Boghuma, you're not allowed to vote on this one. And all right, there we go. So pre-session, how knowledgeable are you about epidemiology regarding Mpox Clade I? And slightly knowledgeable to somewhat knowledgeable at the preponderance of answers. And on confidence about management of patients with Mpox Clade I, anywhere from not at all confident to fairly confident, with nobody completely confident. You are all my kind of people. All right, with that, let's go to the next slide. And I'm going to turn it over to Dr. Grein for the case presentation.
Yeah, hi, thank you. It's really nice to be here. Thanks, Dr. Isakov. Let me share my slides. I hope I can do this easily here. Just need to put this in presentation mode. Would someone just kindly let me know that they can see this okay?
You're good to go?
Looks good.
Okay, thanks so much. Yeah, appreciate it. And I respect the fact that nobody said they were completely confident in their management of this disease, which I think is appropriate. We're all still learning about appropriate management of this. So I was asked to put together a case presentation of an Mpox case for Clade I. I'll just acknowledge right up front, there is little in the literature about Clade I cases that have been exported from endemic areas. So this, what I'm sharing here is a hypothetical case presentation based on information that is available. And I do believe this is a fairly realistic potential scenario, but just walking through this. So the case we're presenting this morning is a 35-year-old male with HIV who's presenting to the emergency department with a chief complaint of a painful rash and fever. Reports 4 days prior he'd observed nodular penile lesions that were initially pruritic but have progressed and now have become painful vesicles with ulcerations. The day before, so yesterday, he developed fevers, similar lesions on his face, trunk, and extremities. He also reports oral lesions with some pain. On further history, he had states that he had returned from Central Africa, specifically Rwanda, about 9 days prior. And while there, he had had an unprotected sexual encounter with another male the day before heading back to the United States. On exam, it's notable for the patient is febrile. He has bilateral inguinal as well as axillary lymphadenopathy, and there are multiple discrete pustules and vesicles across the face, trunk, arms, oropharynx, and in a penile region. Lesions on the trunk have also begun to coalesce. There's also some surrounding warmth and erythema. No ocular lesions are identified. He is able to tolerate oral medications and food and water. Testing for other concurrent STDs such as HSV, syphilis, gonorrhea, chlamydia are all negative. A swab of the penile lesions specifically has come back positive for an orthopox virus that is subsequently sent for additional analysis, which has identified this as a Clade Ib Mpox. Some additional information as you're being brought in to help with the management of this patient. The patient is HIV positive, as I mentioned. It reports intermittent compliance with medication, notes his last CD4 count was about 154. He notes also that he lives in an apartment with a roommate who is currently asymptomatic and describes his last sexual contact about approximately 10 days ago while in Rwanda, as previously described. With regards to vaccination history, the patient reports being up to date on all of his routine childhood vaccinations, which would include varicella zoster vaccine, however, has not received the Jynneos Mpox vaccine. So just a little bit more in terms of follow-up for this case. And again, this is a hypothetical case based on some real case studies. But this patient is admitted to a single patient airborne isolation room. The PPE that is recommended and used includes gowns, gloves, eye protection, N95 respirator. He's initiated on oral tecovirimat, in addition to supportive care and pain control. In discussion with public health, options such as brincidofovir, vaccinia immune globulin, cidofovir are discussed and considered, but are held, at least in this case, pending evaluation of initial response to tecovirimat. In addition, his primary HIV medication is continued. In this case, you could see the bictegravir-based regimen. No adjustments are needed. Vancomycin is initiated for a secondary cellulitis. And public health is informed and involved in contact tracing for all potential close contacts, which would primarily include household or apartment contact in this case. And I think I'll conclude this case by saying, fortunately, in this scenario, by the third hospital day, it does appear there is some improvement in the lesions. The presumed secondary cellulitis has responded to antibiotics, and it appears the patient is leaning towards recovery. So just to summarize a few things with regards to this, and I'm sure our other speakers will touch on this in more detail, but Mpox Clade I has been associated with higher rates of severe illness as well as increased transmissibility compared to Clade II. Clade II, of course, the clade that was responsible for the large global epidemic that we witnessed a few years ago now. However, despite the more severe course that we typically see with Clade I, clinical management, including infection control measures and treatment, are largely the same for Clade I and Clade II. They're clade agnostic. So the same treatment recommendations and infection control measures are recommended for either clade. Mpox Clade I should be considered in anyone with Mpox symptoms, in particular who has recent travel to areas where Clade I is currently spreading, and at this moment that is largely Central and Eastern Africa. Although there have been case reports of sporadic cases largely associated with travel outside of those endemic areas. But these are Central and Eastern Africa remains the area where the vast majority of transmission is occurring for Clade I. It is important to notify public health and request, if not already done, clade-specific testing in any orthopox-positive patient that has recent travel to an area where Clade I is spreading. It's important to note that not all orthopox-based tests are going to automatically do clade-specific testing for Mpox, and so it is important to make sure that that testing is recorded if you is performed if you have a patient that has traveled from an area or has a risk for Clade I. And also, the two-dose Jynneos vaccine should be recommended for adults that are traveling to an area where Clade I is spreading and who also anticipate participating in higher risk sexual practices. And this is my last slide, and I'm not going to read through this. This can be included in anything sent out, but just listing some specific references, including some case reports of Clade I Mpox cases that have been reported outside of endemic areas. As I mentioned, which I think is fortunately good news, there haven't been too many published yet, but just adding these references here for anyone that would like to look further. So I think with that, it concludes my section, and I'll hand it off to the next speaker. Thank you.
Thanks, Dr. Grein. All right, the next speaker is Dr. Titanji.
Yes,
I'll turn the podium over to her.
Thank you. I'm going to share my slide right now. Can everybody see my slides?
Yes, ma'am.
Yes. So I'm going to provide a brief overview of Clade I Mpox, focusing on the clinical presentation, diagnosis, and management. As we all know by now, Mpox has two major clades known as Clade I and Clade II, and Clade II primarily circulates in West Africa and was the clade that was responsible for the global outbreak that we saw in 2022, and that is still continuing to a much lower extent up until now. Clade I, on the other side, is more focused around Central Africa. And actually, one of the countries which is at the intersection between West and Central Africa is the only country that has reported both Clade I and Clade II. So Clade I and Clade II virus do circulate in Cameroon. The ongoing outbreaks that are happening in Central Africa are primarily caused by Clade I virus. Now, both Clade I and Clade II Mpox are further subdivided into subclades. So Clade II has Clade IIa and Clade IIb, and the outbreak that occurred in 2022 was primarily driven by Clade IIb virus. We also recently now know that Clade I has a new emergent subvariant known as Clade Ib, and previously historic cases of Clade I had primarily been Clade Ia. And I'll go into the differences between the subclades in subsequent slides. Now, in terms of the epidemiology and transmission, we know that all clades of Mpox, be it Clade I and Clade II, are primarily transmitted by close skin-to-skin contact with an infected person who has active lesions. Now, it's important to note that although Clade IIb and the outbreaks that we saw across the world in 2022 were primarily through close skin-to-skin contact between humans, when you look at historical reports of Clade Ia, these outbreaks have primarily been associated with exposure to infected animals. So it's primarily been seen as a zoonotic type of outbreak or zoonotic type of strain. And the outbreaks that have happened in humans have tended to be much smaller with very limited human-to-human transmission. Now, at the end of 2023, there was the first outbreak describing the emergence of Clade Ib, which is the newest strain of Clade I, which was exhibiting characteristics that are quite similar to what we saw with Clade IIb in 2022. So more sustained human-to-human transmission and also transmission facilitated by close sexual contact, heterosexual contacts in sexual networks in the DRC and in Central Africa. Of note, it's important to know that while we have these human-to-human transmissions that have been described with Clade IIb and now with Clade Ib virus, Mpox, compared to other infectious diseases like smallpox or even measles, tends to have a much lower reproduction number. So, for example, with measles, if you have an individual infected with measles, they can go on to pass that infection to up to 16 close contacts, whereas with Mpox, the risk of exposure and further transmission to seed new transmission chains, that R0 number is more between 0.8 to 2.5 in range. And certain studies have reported that R0 number tends to be higher for Clade I infections when you compare them to Clade II infections. So pointing towards that slightly higher transmissibility of Clade I virus compared to Clade II. And this here just focuses you again on the epidemiology and transmission differences between clades. And because our talk is focused on Clade Ib, I just want to draw your attention to some of those striking differences in what we are seeing between the two subclades of Clade Ia and Clade Ib. Now, a lot of the Clade Ia cases were those that were historically reported from the first time that Mpox was identified as a human pathogen in the early 70s up until 2024. And as I mentioned before, transmission is primarily mediated by zoonotic exposure, with up to 70% of cases of Clade Ia reporting a zoonotic exposure with limited human-to-human transmission after that initial zoonotic introduction. The incidence tended to be quite low up until 2010, when we started seeing more cases of Clade I Mpox being reported primarily in the DRC. And this is a subclade. In that particular subclade has primarily mostly infected children. And when you look at historical reports of outbreaks, 90%, up to 90% of cases of Clade I reported in these historical outbreaks have occurred in children under the age of 15. Now, fast forward to 2023 and the outbreak that first described Clade Ib. This outbreak was described in the eastern region of the Democratic Republic of Congo and was characterized by more sustained human-to-human spread, which had not been previously described. Now, it was also noted that this new subclade was spreading primarily among adults, with sexual networks playing a significant role. And I wouldn't spend a lot of time talking about Clade II here, but when these slides are shared, I'm sure you can delve into some of those differences in the different subclades of Clade IIb. Now, this again just hones in on the ongoing outbreak in the DRC, showing you some of the epidemiological curve and the progression of cases of Clade I that have been reported through time. As I mentioned before, Clade I really started creeping up in terms of the number of reported outbreaks around 2010. And as you can see, from 2016 up until 2024, we've continued to see a steady increase in the number of reported cases. And these epigraphs are from the DRC. Now, in the outbreak that was recorded in 2023, at the end of 2023, that led to the identification of Clade Ib, that outbreak occurred primarily in the southeastern region of the DRC, whereas outbreaks of Clade Ia have primarily happened in the northwestern region of the DRC. So there are both clades circulating within the DRC, which is a massive country, but those clades are circulating in different regions of the country at this time. There's also been regional spread to all of the surrounding African countries that neighbor the DRC. And so far, the WHO has reported that there have been over 50,000 suspected cases of Clade I virus reported during the outbreak between 2023 up until now, resulting in about 900 suspected deaths. As the previous speaker mentioned, there have been exported cases of Clade Ib also reported in European countries, and one case has been reported in the United States. So turning our attention to the clinical features of Clade I Mpox, and I'll focus here primarily on the differences that exist between how Clade I Mpox presents and Clade II presents. We know that across the clades, most individuals who contract Mpox tend to have some sort of prodrome reporting systemic symptoms like fever, fatigue, and headaches that precede the appearance of a rash. Now, Clade I infections tend to be a lot more severe than Clade II infections, and this severity is denoted primarily by the number of lesions that individuals present with. So these figures are taken from the ongoing outbreak, a recent review on Clade I Mpox in the DRC, published in the Lancet just 2 weeks ago. And as you can see on this infant, they have lesions that basically cover their entire body. And here again, in an adult female, showing you genital lesions. And if you really hone in, you would see that they're that classic papular lesion that tends to have a central umbilication that is really distinctive for orthopox viruses. Now, in the DRC, the Clade I viral rash has primarily been described as having a centrifugal pattern starting in the head and then spreading to the rest of the body. And over 90% of patients present with more than 100 lesions. Now, imagine when you compare this to Clade II infections, Clade IIb infections that we saw in 2022, sometimes you would see individuals presenting just with isolated genital lesions. But for Clade I infections, these tend to be a lot more disseminated in nature. Now, 70 to 80% also present with enlarged lymph nodes, and they can have complications such as secondary bacterial infections, resulting in sepsis in up to 20% of individuals, respiratory symptoms that can happen in 11% of individuals, as well as GI symptoms in about 8% of individuals. Now, in the Clade Ib outbreak, mostly adults with a median age of 22 years have been reported as presenting with Clade Ib, and 50% of infected individuals have been shown to be women, with 30% of this being commercial sex workers. Now, remember I mentioned that the Clade Ib outbreak was first described in the southeastern region of the DRC. This is a region that is also very rich in mining activity and cross-national travel between the DRC and other countries. So it's also an active hub for lots of commercial sex workers. And this appears to be fueling, to a certain degree, the spread of the virus from person to person. It's important to note that in the adults that have reported with Clade Ib, up to 85% of cases have presented with genital lesions, again, pointing towards that role of sexual transmission for this clade. And in one study, although 91% were hospitalized primarily for isolation purposes, only 10% of individuals experienced severe respiratory issues. Now, infections have been associated with pregnancy loss, and it's now very well described that Mpox infections are teratogenic and can lead to stillbirths and early abortions. And also, the case fatality rates appear to be a lot much higher in children and immunocompromised individuals, like people with poorly controlled HIV, in the same way that was described with Clade II infections. Now, this table, again, summarizes some of those key features and key differences between the clinical presentation of Clade Ia, Clade Ib, and the sublineages of Clade II, which we're not focusing on today. And as you can see here, the primary differences are the differences in age, the fact that you have children more impacted by Clade Ia infections and adults more impacted than Clade Ib. But also you still see similar rates of systemic symptoms like fever, cough, sore throat, myalgia. And here, a lot of the data that we have in terms of distribution of the rash is primarily available from Clade I outbreaks, because those have been around for much longer, and we're just having data recently emerging from Clade Ib, and hopefully in subsequent talks, we'll be able to show you data on some of these columns. So turning our attention to diagnostic considerations, I think it's very important, as the previous speaker mentioned, to have relevant history when you're considering a patient in whom you may be suspecting a Clade I Mpox infection, because right now, primarily, the outbreaks are still really concentrated and focused in Central African countries that neighbor the DRC. And a lot of the cases that have been reported outside of this region have primarily been linked to travel. So if you had an individual who had traveled to a country with an active outbreak, who presents with a rash that is suspect for Mpox infection, then in the back of your mind, you should be thinking about whether this could potentially be a Clade I infection. In terms of confirmatory diagnostics, all Mpox diagnosis is confirmed by isolation of the virus DNA by PCR from a swab that is collected from the lesion. Now, it's important to note that some of the available PCRs, notably the commercially available PCRs that are set up in different hospitals across the US and in some diagnostic labs, primarily target the C3L gene, which in Clade Ib infections may have deletions that make this PCR less sensitive in its ability to detect this particular subclade of Mpox. So if you suspect that you may be dealing with a Clade I Mpox infection, it's important to make sure that that sample is forwarded to a reference laboratory for confirmatory testing. Now, in terms of what other findings on testing can make you suspect that you may be dealing with a Clade Ib Mpox, if your non-viral orthopox PCR is positive, but your Clade IIb PCR, specific PCR returns negative, then you should be considering that you may be dealing with an orthopox virus infection that is not Clade IIb, in which case you want to send it for sequencing and further characterization, for instance, by the CDC, to make sure that you're not dealing with a Clade Ib infection. In terms of management, Mpox treatment currently, be it Clade I or Clade II, primarily relies on supportive care to manage symptoms and complications. And when we talk about supportive care, we're primarily thinking about pain relief for individuals who present with the rash, because the rash can be both itchy and painful, providing hydration, because imagine with a disseminated rash and over 100 lesions on the body, a lot of these individuals are losing a lot of fluids from their cutaneous lesions and need to have hydration support, and also treating secondary bacterial superinfections, which are quite common with this disseminated type of rash. Now, tecovirimat is the antiviral drug that was widely used under emergency use authorizations during the 2022 outbreak, and is an antiviral drug that acts by preventing replication of the virus and has been shown to be effective in animal models and in vitro. However, we've had lots of disappointing results from the 2 clinical trials that have looked at the efficacy of tecovirimat in shortening the course of Mpox, be it Clade I Mpox in the PALM-007 study that was conducted in the DRC, and more recently, the STUMP trial in the US, which was focused on looking at the efficacy of tecovirimat for Clade IIb infections. Neither study showed this antiviral drug to be effective in shortening the course or promoting the resolution of lesions. So currently, we don't have any clinical trial data to support that this drug is useful to treat this particular viral infection. Now, the role of tecovirimat and other antivirals like brincidofovir and cidofovir remains to be investigated in severe infections that involve immunocompromised individuals. And these are hopefully studies that we will see in coming months to years. So, as I mentioned, most individuals would recover with supportive care within 2 to 3 weeks. In terms of management of severe cases, it's still important to and recommended to reach out to the CDC experts and consult with them on how to manage these cases. And I've put here the CDC Emergency Operations Center number for those who may not know it. And you can reach out to this number and request a clinical Mpox consult in patients that present with Mpox that is severe and for whom you need guidance in terms of management. In speaking with experts at the CDC, you may be able to get access to antiviral drug combinations or even access to vaccinia immunoglobulin intravenously on a case-by-case basis. And all of these treatment approaches and strategies are usually based on expert opinion and guidance based on their experience with treating other severe cases. Now, moving on to vaccines and important considerations for Clade I Mpox, it's also important to note that all the current vaccines that we have available for Mpox are based on a different virus. They're based on another orthopox virus called vaccinia virus, but that virus is able to generate immunity that is cross-protective for monkeypox virus itself. And we have MVA-BN, or also known as Jynneos vaccine, which is currently licensed for prevention of Mpox. And we know based on case control studies that were done in the US that this vaccine has modest efficacy of about 75% after one dose and about 86% in individuals who have received 2 doses. In terms of efficacy data, where Clade 1A and B Mpox are concerned, we don't have efficacy data for MVA-BN vaccine yet. But this currently remains the mainstay of vaccination for vaccine prevention, and this vaccine is being rolled out actively in African countries that are currently experiencing outbreaks. It is still recommended to continue to offer vaccinations to individuals who meet criteria for vaccination, particularly individuals who may be more likely to be exposed to Mpox. Or it's also important to consider offering vaccination to people who may be traveling to countries with ongoing active outbreaks of Clade I Mpox. In conclusion, Clade I Mpox outbreaks in Africa continue to be a public health emergency of international concern. And clinicians have to have a heightened awareness, especially in patients who present with the relevant epidemiologic context and the relevant clinical presentation. It's also important to engage referral laboratories like the CDC promptly for confirmatory testing and for assistance with management, particularly in severe cases. And I can't stress this enough, continue to offer Mpox vaccines to all those who meet criteria. These are my references, and I'll pass it back over to the moderator. Thank you.
Thank you, Dr. Titanji, and also Dr. Grein. If I can get both of you to turn your cameras on, it's Q&A time. Awesome. All right. Well, I've been monitoring the Q&A tab, and your presentations were so beguiling that we don't have any questions in this moment, from the audience, which is a great audience of 280 participants at this point. But there were questions that were submitted in advance. And so I'm going to try to get some of those questions answered. The first one, actually, I'm going to ask Dr. Titanji to answer because she had addressed this question regarding clinical evidence on the effectiveness of tecovirimat for the treatment of Mpox infection. And the question, you answered that question in your presentation. I guess the question is there any clinical utility to using that drug given the current evidence?
Currently, we don't have any evidence that in individuals with uncomplicated Mpox infection that there's any added benefit for using tecovirimat. In the PALM-007 study, they compared individuals on tecovirimat to individuals who received standard of care that involved pain management, hydration, and nutritional support. And they found that there was no difference and no added benefit of the antiviral drug. In the STUMP study, it was discontinued, or the study was terminated earlier because, again, of futility and not really showing any demonstrable benefit of tecovirimat. However, it's important that in both to note that both in the PALM-007 study and in the STUMP study, they did not specifically focus on answering the question whether tecovirimat provided benefit for immunocompromised individuals with severe Mpox. And I think that this is the one area where we still have questions and we don't have clinical trial data that supports or refutes its benefit in that particular scenario. So in order to use it for that gray area, that's why I was stressing the importance of consulting with the CDC Mpox specialist group to help make some of that shared discussion, whether there are still clinical scenarios for which there might be some benefit in offering tecovirimat. But right now, for the general public, the answer is we don't have any benefit that it adds anything.
Thank you for answering that question. Jonathan, something to add?
Yeah, if I completely agree with everything Dr. Titanji just said, and I'll just add to emphasize that, yeah, as you mentioned, the study design was such that if you look at the STOMP trial, for example, those who had risk factors for severe disease or severe disease were not randomized and were in fact provided the drug in an open label approach. So just as Dr. Titanji said, we really can't draw conclusions about the efficacy of this treatment for those at risk for more severe disease. And I think that's a very important point to emphasize. Also, the studies both did show that the treatment was well tolerated with minimal side effects. So there are some important takeaways from those studies. It was, of course, frustrating to see there was no benefit for those with milder disease. But I just want to be careful about the conclusions we draw from those studies.
Yeah, thanks so much. Important point. Some live questions have come in, so I'm going to try to turn your attention to those. The first question in the live session is, can you explain the rationale for placing a patient on airborne isolation? Anyone want to tackle that?
I can try to tackle that. I think just to be clear, there's no clear evidence epidemiologically of airborne transmission. However, and we see this as a public health approach for emerging diseases for which we don't have a lot of data. There's always the tendency to want to err on the side of caution. And so I think that is largely the reason for those recommendations, particularly in hospitalized settings where patients may have more severe disease and may undergo aerosolizing procedures for which there is some risk of aerosolization that we just don't completely understand. So I guess I would summarize that by saying those recommendations for airborne isolation in healthcare settings are really out of an abundance of caution and just respecting the fact that we don't really know too much about transmission in those specific settings.
Thank you, Dr. Grein. Dr. Titanji, there's a new question that came in as a follow-up to the answers that were provided on the tecovirimat. And the question is, well, it may not shorten the course of illness, but can stop viral replication. Would this help reduce viral load and reduce transmissibility between, let's say, the patient and healthcare personnel or any other close contact?
Yeah, that's a very good question. And I think that one of the unanswered questions around tecovirimat use is whether it has any benefit as post-exposure prophylaxis or as pre-exposure prophylaxis, right? And those studies have not been done. So we don't know the answer to that. We know from animal studies that it does reduce viral replication. We know from in vitro studies that it does reduce viral replication. But to recommend it for pre-exposure prophylaxis or post-exposure prophylaxis, you will have to have a clinical trial that had individuals randomized to the intervention compared to a placebo. So the answer to that is we don't know if it has benefit for those particular indications, but it's important to study them.
Great, thank you. Embedded in that question also was a question about the infectiousness of Mpox. When do you know that the patient's no longer shedding virus?
The general sort of like rule is that when the individuals who have active lesions, that is lesions that have not fully healed and scarred over, are infectious. Like if you swab those lesions, you're likely to retrieve viral DNA. So we say people are not infectious generally when they have fully healed their rash, as in they have new skin and reepithelialization over the lesions that you saw shown on some of those images there. And for most individuals, that takes 2 to 3 weeks. We know from studies that were done at the CDC, by the CDC, looking at individuals who were discharged from hospital and still had Mpox lesions, that virus was detected in their environment, in the bed, on their clothing for until their lesions healed. So for several weeks, as long as they still had skin lesions, they still had detectable virus. So people heal when they no longer have active skin lesions.
Great, thank you for that. We touched a little bit on post-exposure prophylaxis. Can someone answer a question on the benefit of post-exposure vaccination and how that might afford some protection?
Well, happy to start, but of course, Dr. Titanji may add. I think in general, with regards to the vaccine, it can be considered. The general guidance is it can be considered for post-exposure prophylaxis. Of course, that's provided it's given as early as possible. So I believe the general recommendations are, if it's within 4 days of an exposure, it would be advised as a form of post-exposure prophylaxis, and that there may be some benefit if it's given out to 14 days as well after exposure. Beyond 14 days, there's probably not much of a benefit, although I would argue that for those that are not vaccinated who may be at risk of future exposure, that it'd be a good opportunity to provide vaccine anyway for primary prevention. But those are the general recommendations for post-exposure prophylaxis. And it may not prevent infection completely, but it may reduce severity if infection does develop following exposure.
Thank you for that. That question's a bit tied to perhaps the incubation period for the virus until clinical manifestation of the illness. I think that was presented, but there was a question in the audience. Can someone just answer that quickly?
The incubation periods that have been reported, both for Clade II virus and Clade I, have actually been they have quite a wide variability in terms of how long that incubation period is. And generally, the numbers that you would see in reviewing the literature range between 5 days to 21 days. And some of that duration in incubation may also be down to how much inoculum the person was exposed to at the time of the transmission event, which explains some of that variability. And going back to Dr. Grein's point on post-exposure prophylaxis, that's why you have that recommendation range of trying to give it as soon as possible for individuals within 4 days of their exposure, but up to 14 days, sort of acknowledging the fact that incubation periods for Mpox can be quite long, depending on the inoculum, the virus subclade that you're dealing with, and the mechanism of transmission.
Great, thank you. Staying on the topic of protection from infection, there's a question regarding the Jynneos vaccine versus ACAM 2000. And the question is, which vaccine is recommended for the immunocompetent healthy individual traveling to Clade 1B areas?
Do you want to take that, Dr. Grein?
Well, maybe we could tag team that, but I think
sure.
in general, I think in general, I will acknowledge I've only really had experience with the Jynneos vaccine for us, and that's been generally pretty well tolerated. So I believe that's the general kind of recommendation, at least for here in the United States. But Dr. Titanji?
Yes, I would say that most people right now, what we have access to is the Jynneos vaccine, and that's what we've been recommending. However, prior to the outbreaks of Mpox in 2022, if you were a laboratory worker or someone who worked closely with isolates of orthopox virus or Mpox, there are individuals in our research lab who have received ACAM 2000. Now, ACAM 2000 is not recommended for immunocompromised individuals. It's not recommended for pregnant people or people who have untreated HIV. But if you're immunocompetent, you can receive the ACAM 2000 if you have access to it. And we did carry out a study in the Atlanta VA that assessed the efficacy of individuals who had received ACAM 2000 as part of pre-deployment vaccination in military personnel to see whether that vaccine was effective against Mpox. And the efficacy level of ACAM 2000 was about 72%. So again, very comparable to the levels that we are seeing with the Jynneos. It's important to note that ACAM 2000 is a live it's a live vaccine, so it's replication competent, whereas Jynneos is an attenuated vaccine that is replication limited. So, and it's ACAM 2000 is a single dose vaccine. It's given through a scarification method, which is a slightly different way of administering the vaccine compared to Jynneos vaccine that can be given either subcutaneously or subdermally. So those are kind of like some of the differences.
Perfect. Thank you. Um, uh, Continuing on the topic of infection prevention, there's a question in the chat about any recommendations refraining from sexual activity for any period of time after infection to prevent transmission.
Yeah, I can start and then maybe Dr. Grein can comment. In terms of there have been studies that were done during the Clade IIb outbreak. Some of these studies came out of our European colleagues, particularly one study was done by an Italian group that looked at the period, how long people who had fully recovered from Mpox Clade IIb infection continued to have detectable Mpox virus in their semen. And in that particular study, they followed individuals up to 3 weeks post-recovery. And that was the latest time point at which they continued to detect virus. Now, for Clade 1, A and B, we have not had similar studies exploring and looking at the detection of infectious virus in seminal fluid. So the general answer is we really don't know if for how long we should be recommending barrier protection in these individuals. That's an area that still needs active investigation. But in general, we would advise people who have active lesions and who are still experiencing symptoms as they recover from Mpox to try and refrain from unprotected sexual activity until when they're fully recovered.
Great. Thank you very much, Dr. Titanji. Dr. Ryan, anything to add?
No, that was a great answer. I don't have anything to add to that. I do think it's important to perhaps, make that point in the discussion when counseling the patients about some of the uncertainty around that. I think it's important to acknowledge that, but no, I completely agree.
No, great. Thank you. We have about a minute or two left before we go to closing remarks. So, of the questions that I have here, there were questions submitted earlier that would be helpful to clinicians that are trying to make that diagnosis and maybe distinguish that rash from Mpox and maybe Clade I versus Clade II. How soon after sending samples would a clinician expect to get an answer, and what type of samples do they need to send?
Yeah, the samples that clinicians should collect are no different from the samples that we recommend clinicians collect for Clade IIb. So an active lesion, you collect a dry swab sample of that. Different institutions have different sample collection protocols. Sometimes you collect a dry swab, or in other institutions, you put that dry swab in viral transport media. Now, once you have that specimen collected, if you contact the CDC, then you can ship that sample to the CDC to be able to do the actual sequencing that would allow them to type the virus that you have. In the context of the Clade IIb outbreak, it was the turnaround time for getting back from our CDC colleagues, at least in my experience here in Georgia, was about 7 days, 7 to 10 days for us to hear back. Now, I haven't had to send a suspected specimen for Clade 1b testing yet, but I would suspect that turnaround time would be similar for this particular context.
Great.
Yeah, I will just briefly add, I completely agree with that, that the clade will not affect your interventions, right?
Yeah.
So your infection control interventions, your treatment recommendations will be the same, but from a public health perspective, it is certainly very important to try to identify Clade I from Clade II from that perspective. So yeah, certainly, as we said before, to ensure clade testing is done for those that may be at risk of a Clade I infection, but it shouldn't affect your clinical management.
Yeah, I appreciate that. And with time coming to an end around Q&A, as an emergency medicine and EMS physician, I have to address the question about how this impacts emergency medical services. And so I'll just quickly say that it's important for EMS personnel and EMS clinicians to be aware of Mpox as a possibility when examining a patient that has a rash. So the identify, isolate, and inform paradigm is valuable. This is especially true for patients that have that travel history, if there's some concern about Clade 1b, Mpox, and then using barrier protection and implementing the infection prevention measures described in the talk, especially as it relates to personal protective equipment, gown, gloves, N95 respirator, and face shields important. And then don't forget to bring your concern to the attention of the team that's going to be receiving that patient in an emergency department so that they can also apply the appropriate personal protective equipment and implement the appropriate infection prevention measures. Thank you both, Dr. Titanji and Dr. Grein, for answering these questions. There are a few more in the Q&A tab. If you have the opportunity just before we close to type an answer, if not, I think the organizers will try to have answers to these questions posted along with the presentation. But with that, let's go to the next slide. And we want to ask the poll question again, which is, how confident do you feel about the presentation and best practices in managing a patient with Mpox Clade I? So let's have the audience put their answers in for that. And Yasmin, you can close the poll when you see you have a good number of answers. All right. And confidence is increased, which is great. 41% somewhat confident, 41% fairly confident, and now 9% completely confident. So confidence is improved. Thank you all for answering that question. Next slide, please. So thanks all for participating today. Don't forget that there is a survey at the end of the program so that you can provide feedback to the organizers about how to improve these programs. And that survey is also important if you're going to submit for the CME or in CEUs. Next slide, please. So if you're interested in the resources that are associated with this particular podcast or interested in future podcasts, you can see this active link and you can subscribe to SCDP Echo Podcasts to be aware of the next presentation. Next slide. Next presentation is actually February 20th, so roughly 1 month from now, regarding H5N1 bird flu. How much time do we have? So use that active link to register. And if you're not able to click on that link here, know that you can get a copy of these slides and can click on it from there. So with that, we're going to close as we're approaching the top of the hour. Again, many thanks to Dr. Grein, Dr. Titanji for your expertise, and special thanks also to Yasmin for making sure that everything's running here on time. And thanks to all the participants that joined and for your many questions. Very interactive group, which was great. And final thanks to Dr. Gavin Harris, who's the typical moderator for this session for providing the Region 4 update. Thanks all, and see you next time. Bye-bye.